Assalamu alaikum wa rahmatullah. I would like to thank the organizing committee and scientific committee for selecting our abstract to be presented in this prestigious conference, and congratulations, it's a really successful event. On behalf of my co-authors from the Department of Hematology and Nephrology at Tawam Hospital, I would love to share with you today our research about the outcomes of acquired thrombotic thrombocytopenic purpura. So TTP is rare and fatal thrombotic disorder. Before you hit me with your questions, I would love to ask you a question in this early morning. So what do you think is the prevalence, the estimated prevalence of TTP worldwide? Any guess? 1 per 100,000? The correct answer is really rare. It's 2 to 6 per million. And the highest report from France. How about the mortality rate if untreated patients? It's fatal. So it's up to 90% mortality rate. So you just only need to remember this because it's really, you have to act fast. Do we have any data when it comes to the GCC countries? The answer to that's only we have 2 abstracts presented, one from Oman, one from United Arab Emirates. And there is a newly published consensus from 3 countries, UAE, Oman, and Kuwait, regarding the management of acquired TTP. The experts estimated it's really rare when it comes to Oman, 1 per million. In UAE, almost similar to the worldwide estimate, and in Kuwait, 4 per million. But again, there is no published data. This is only expert view. So what is the problems when it comes to TTP? There is a deficiency in ADAMS 13. This deficiency could be either in less than 5% hereditary, and you will find it mainly in children or even pregnant women. Majority of the cases, more than 95%, they would have autoantibodies against ADAMS 13. This will give you the acquired TTP. And in this case, you have to remember, you have to investigate for infectious autoimmune malignancy as the underlying cause for acquired TTP. We all remember when it comes to TTP, the 5 dentate: fever, severe thrombocytopenia, microangiopathic hemolytic anemia, and you can see neurological and renal involvement. But do remember, it's only present in 10% of patients. This is not only the issue here, multi-organ involvement has been reported ranging from 60% to neurological all the way to 25% when it comes to cardiac. There is the new advances when it comes to TTP. You can see up there, because of the large multimers of 1 milligram, there will be activation and adhesions with different thrombi and microvasculature. There is, in 2019, a landmark study published, and the first nano antibodies against the alpha-1 subunits binding to von Willebrand, called cablecizumab. This is really a very important drug, but really expensive, but it has reduced mortality and reduced recurrence rate and such fatal disease. So if you suspect patients with a TTP, you have to send ADAM 13s because this will differentiate between HUS and TTP. Then you have these clinical scores. You can use either French score, will have 2 elements: severe thrombocytopenia less than 30, or even acute kidney injury. If you have the 2 scores, it's more than 94% TTP. The other score, which is more worldwide used, the plasmic score, you can calculate based on the, again, thrombocytopenia, coagulation, and presence of AKI. And if you have more than 6 scores, 6 to 7, is almost 85% sure that this might be a TTP. So please remember, if you have a patient with TTP, despite the fact of severe thrombocytopenia, platelet transfusion is really contraindicated. You should not give these patients any platelet transfusion because it will lead to more thrombosis. And when it comes to treatments, you have a cocktail of things. Plasma exchange, number 1. Steroid is there. Rituximab is there. And if you have availability of cablecizumab, then you can utilize it. And this has been supported by ISH latest guidelines published in 2020. And you can see, first, if you suspect TTV, you have to send for the Adams 13. And then this is an emergency case. You have to activate plasma exchange team to do plasma exchange along with steroids. You can start, if you have a patient severe disease, you can start upfront cablasizumab, awaiting the result. Please remember also to give rituximab. When it comes to cablasizumab, this is a once daily injection up to 1 month. So it's not a short course. You have to remember your patients have insurance and it's really costly. Let's move now to our study. We aim to study the management outcomes to TTV in Tawam Hospital. We have done a retrospective study over 7 years, and we have included the adult patients diagnosed with TTV. We looked at their clinical outcomes and the mortality rate on 30 days. And we have used the descriptive analysis because of the small sample size. So what is our result? We have identified 12 patients with TTV, and with a mean age of 41 years, and only one Emirati lady among the cohort. And you can see 58% were males. And the comorbid conditions, majority of our patients, 75% had obesity. And then in terms of other comorbidities, hypertension, 33%, and chronic kidney disease, 25%. What was their clinical presentation? Majority of our patients, 83%, presented with fever and neurological findings that was ranging from simple headache all the way to neurological deficit seizure and even coma. This was followed by jaundice in 58% and bleeding episode, despite the fact this is thrombotic event, thrombotic disease, the bleeding episode in our cohort is really high, around 41%. So the TTV diagnosis was confirmed by the presence of low Adams 13 activity and high inhibitor titers, along with other features. All the patients had severe thrombocytopenia with a mean of 17, along with a macroangiopathic hemolytic anemia, and all of them also had acute kidney injury. Interestingly, around 50% of our patients had a bacteremia on the presentation, and this is very important. They have multiple organisms, salmonella in 2 cases, and the rest you can see there. How about the neurological findings? We had around 33% of our cases had documented acute ischemic stroke in MRI and CT, and subarachnoid hemorrhage 25%. Now, we also interestingly found concomitant disorder. One patient had hairy cell leukemia, another lady had SLE, and one patient had a renal mass suspecting renal cell carcinoma along with IgA nephropathy. So it's really important to find the other factors associated with TTV. In terms of the clinical course, because they present acutely and they were sick, 50% of the patients required critical care admission. 41% required intubation. As I told you at the beginning, all of them had AKI, and 25% required renal replacement therapy. So what was the treatment outcomes in our cohort? All the patients, they had therapeutic plasma exchange with a median of 5 to 7 sessions. Steroid also 100%. Rituximab, when it comes to 83%. Cablasizumab, alhamdulillah, it was available, despite the fact it was FDA approved in 2019. We had it in 2020 at Tawam Hospital, and we have used it in 5 cases. 2 patients had a refractory TTV, 1 had relapsed, and 2 presented with high-risk features. And in terms of the mortality rate in our cohort, 16% had the mortality rate in our cohort, and with the median hospitalization range around 18 days. When it comes to relapse, the majority in our case, which is something unique in our cohort compared to the international figure, the relapse happened in the first 3 months of diagnosis, and only in 25%, lower than what's reported between 40 to 50%. And we have data for 7 years follow-up without recurrence, alhamdulillah. Very important and nice, alhamdulillah, outcomes. All the hematological parameter derangement improved with this therapy, along with there was no neurological deficit, and 1 patient had progressive CKD. So in conclusion, TTV is a really rare disease, but really fatal, as I told you. If you diagnose it early, you have to manage and hit hard with plasma exchange, corticosteroid, rituximab, and cabtuzumab is available. The Bentaid that was, I told you, in literature is less than 7%. In our cohort, it was 75% of the patient presented with a Bentaid. And it's really rare. One Emirati lady among the 7 years study, and you have to suspect infectious causes, malignancy, or even autoimmune disease. With that, I would love to tell you that this is the first step in establishing, inshallah, the first national TTB registry, and hopefully moving it to the GCC TTB registry. With that, I'll leave you in peace and thank you for the